I just want to welcome everyone to our webinar this afternoon. I'm Lydia Chwastiak. I'm a psychiatrist and professor in the Department of Psychiatry at the University of Washington School of Medicine, and I am a co-director of the Northwest Mental Health Technology Transfer Center. And I'd like to welcome everyone to this afternoon's webinar on behalf of our Northwest MHTTC and also on behalf of our partner, the Behavioral Health Institute at Harborview. This is the third webinar in a series that aims to support community-based behavioral health providers in Washington in their implementation of telehealth services. We appreciate that the capacity to provide effective telehealth treatment has become an urgent issue in the context of the COVID-19 pandemic, and we know there are a lot of questions as organizations are ramping up services on a very accelerated timeline. We had two terrific sessions last week, and I'm really delighted to welcome the panel back today. Along also with some expert presenters on today's topic of billing and reimbursement. And just a reminder that we're doing sessions on Wednesday afternoons and Friday mornings. The Wednesday sessions will focus on administrative and technical issues, and the Friday sessions will be much more clinically focused. And as we did last week, we're really trying to structure these sessions so that we can get the we can use most of the time to dedicate to Q&A and discussion with our speakers and our expert panel. So on the next slide, just kind of an overview of our MHTTC network. This is, we're a national network that's supported by SAMHSA to support the behavioral health workforce to implement evidence-based practices for mental health disorders. Our Northwest MHTTC is based at the University of Washington in the Department of Psychiatry, and we provide training and technical assistance to Region 10, which is Alaska, Idaho, Oregon, and Washington. The next slide shows broadly our goals, which are to ensure the availability and delivery of free, publicly available training in TA to Region 10 providers, but also to heighten the awareness, knowledge, and skills of the behavioral health workforce to address the needs of individuals with serious mental illness in particular, and to accelerate the adoption and implementation of mental health-related evidence-based practices across our region. It is our intention to always use culturally appropriate terminology and language that promotes recovery. So we encourage all presenters and participants to use person-first language, which emphasizes the individual and not a condition or disability, in order to promote treatment and training environments that foster respect, dignity, and hope. So we have a couple of logistics. Before I introduce the speakers, we have a couple of logistics to review. There are a couple of functions that are available to you as participants. You'll notice that there's a chat box. So this chat box is really visible only to our support team. And this is for any technical issues you're having. So if you're having any trouble with audio or just chat into the chat box, and one of our staff will respond to you in the chat box. What we really want to focus on getting your feedback and your questions for the speakers and the panelists. So if you have content questions, do not put them in the chat box, but instead put them in the Q&A, which is a couple of icons over. We really want you to ask questions, tell us your challenges, and provide feedback to our speakers and our panelists. We're a large group on these calls, so everyone will be muted during the call, during the initial presentation. So we're not going to interrupt our speakers for people to ask their questions, but we are saving 30 minutes at the end for our experts and panelists to answer questions. There are two ways that you can ask a question. So you can type it into the Q&A box, and the speaker will get to it after the presentation, or you can raise your hand and one of the panelists will unmute you so that you can ask your question. Our panel will be monitoring the Q&A box. Some of your questions will be, they'll be able to answer very quickly, and so they'll just type in answers. But our panel will be monitoring the Q&A box and organizing questions. We'll do our best to get to as many questions as we can. Our goal is to rapidly incorporate your feedback into subsequent sessions in the series. So we also are providing you an opportunity to give feedback through a survey that will be available to you at the end of this session. And an email after the session. As all of our MHTTC trainings and resources are free, we're required by SAMHSA to conduct a survey and an evaluation, and so your participation helps to support and improve trainings like this series. So we'll put this into the chat, the link to this survey into the chat box at the end of the session. So our panel on the next slide is the same group of experts. Whoops, not on the next slide. Our panel is the same group of experts from our sessions last week, and they have expertise in technical and administrative policy issues related to telehealth. But the focus today is on telehealth billing and reimbursement. So I'm delighted to introduce today's speakers. Gail Krieger is the section manager of the Medicaid Compliance Review and Analytics section of the Medicaid Program Operations and Integrity Division in the Washington Healthcare Authority. This section is responsible for the oversight of the managed care organization's administration of the Medicaid benefit and the quality of care provided under Medicaid. So Gail will have the expertise around Medicaid questions, and then Catherine Britton is our other expert panelist. She is the Executive Director of the Telehealth Alliance of Oregon, a membership organization focused on telehealth policy development and education for healthcare providers, policymakers, and payers in Oregon. She's an advisory board member for the Northwest Regional Telehealth Resource Center and contributes her expertise in billing and reimbursement for telemedicine to their Telehealth 101 workshops. So at this time, I'll turn it over to our partner, the BHI, Melody McKee from the Behavioral Health Institute, to say a few words about the BHI and then get our speaker started.
Thank you, Lydia. If we could go to the next slide. The Behavioral Health Institute. I'm the program director for the Training, Workforce, and Policy Innovation Center, and it's through this work that we are delighted to be partnering with the Northwest MHTTC to provide this training series. The Behavioral Health Institute is rooted in improving care for youth and young adults with early psychosis, creating behavioral health urgent care walk-in, expanding digital and telehealth services, and then the program that I've already mentioned. And we're excited to be here today. Thank you. So the next thing we're going to do is bring up a poll for you. Now that you've heard a little bit about who we are, we'd like to know who you are. The poll is going to ask you what category of provider you're coming to us from. Are you a prescribing provider, a nurse or other medical worker, a behavioral health clinician or therapist, case manager, outreach worker, administrator, tribal behavioral health or tribal health organization, education, school or school-based organization, or clinical supervisor. So if you could take a second to answer that poll for us. It looks like we've got quite a few administrators on the call today, behavioral health clinicians and therapists, one prescriber, a couple of nurses, some tribal representation here, and some education representation as well. So thank you for participating in the poll. The results are, we've got about 28% behavioral health clinician and therapists, 34% administrators, and a few people from each of the other categories, including 14% clinical supervisors. I will let you know that you will need to X out of the poll on your own screen so that you can see the next slide and as we move on into the presentation. I'm going to turn it over to our presenters.
Hi. This is Gail Krieger, and I'll be speaking to you about building telehealth capacity for behavioral health, telehealth billing and reimbursement in the Medicaid program in Washington State. This session, we will be covering the objectives of reviewing the Medicaid billing and reimbursement for telehealth during the COVID-19 public health emergency. We'll be reviewing the Medicare billing and reimbursement for telehealth during during the COVID-19 public health emergency, and we'll be reviewing private payer billing and reimbursement for telehealth during the COVID-19 public health emergency. As a note of disclaimer, any information provided in today's talk is not to be regarded as legal advice. Today's talk is purely for informational purposes. Always consult with your legal counsel. And this presentation is based on information that was available as of 4/25/2020. So I'll be speaking to you more specifically about the Medicaid Apple Health and our program that we have implemented. to support telemedicine and telehealth in our delivery model. So to provide you an overview of the telehealth, telemedicine policies that the Healthcare Authority has for Apple Health Medicaid program, we want to acknowledge that in the healthcare community, the words telehealth and telemedicine are often used interchangeably. But what we want to try to convey to our providers and the billers for those providers is that for Washington Medicaid, telemedicine is defined under state law as a very specific type of modality. It is defined as the delivery of healthcare services through a HIPAA-compliant, interactive audio and video technology that permits real-time communication between the patient at the originating site and the provider for the purposes of diagnosis, consultation, and treatment. Then with the development of the COVID emergency, we decided that telemedicine alone was not going to be sufficient to support the delivery of care and access to care that was going to be required to support our clients during this time of limited in-person access. So we have expanded our program to now include a telehealth modality. This is an umbrella term that includes telemedicine as well as other temporary policies that include technologies that may not be HIPAA compliant, and they may not be conducted through interactive audio-video exchange, such that you may be using Skype or FaceTime or the telephone. So very specific types of interventions that are not consistent with the definition of telemedicine. These telehealth policies were implemented to expand the types of telecommunications that can be used to provide assessment, diagnosis, intervention, consultation, supervision, and information, and are delivered in lieu of the in-person visit. So when I refer to tele policies, I'll be referring to both telehealth and telemedicine. It's less than a mouthful that way. So HCA is adhering to its current telemedicine policies, but it's added a new telehealth policies that will be effective through this pandemic. We are instructing providers to use the CPT or HCPCS codes that would be billed if the person were to have had the encounter in person. We are paying the same amount, which is referred to oftentimes as parity, for a televisit as it would be if it were in person. We are offering additional codes to be used as well when the CPT or HCPCS code is not the best option. So for telephone calls, with new or established patients, you can bill the 99441 through 99443 code. If you're using online digital exchange via patient portal, you can use 99421 through 99423. And then we have an option for a brief virtual check-in, which we are also expanding to include texting. And that would be with an established patient. And that would be the G2012 code. For telecontacts, we have also just recently added an add-on code that will reimburse an additional amount for visits that are conducted outside the Monday through Friday 8 to 5 hours and on weekends. And those are the 99050 and 99051 codes that are available for that, reporting that interaction. Want to provide, to say to you that this is a very high-level review, and we want to refer you to what we call the Behavioral Health FAQ for specifics on the policy, how to bill, and who may bill as you move forward with providing teleservices and billing for those services such that it supports payment. I think that I just want to share with you some key points or some tips that might help. Some of this is based on inquiries we have received to date. Been a lot of time spent providing guidance through email. And so to just encourage people to read the entire behavioral health FAQ. Some parts are very general in the information, specifically parts 5 through 6, and this is applicable to every provider that might be billing. So we want to encourage people to look at all of the pieces of the FAQ. I think that some folks are struggling with the transition of moving from the in-person visit billing that they're accustomed to now adapting to this new delivery model. And so I want to offer that we've tried to keep this as consistent as possible. You want to think about the FAQ as you would if you were billing an in-person visit, and you want to look at the section that's applicable to the benefit that you are using, that you use to provide the service, that what you are billing for, or who you are billing for, who received the service, such that if you are an individual who is providing a service that would be reported in SERI, then you want to use the Part 1 of the FAQ. If you're providing a service that is consistent with that described in Part 2 of the Fee-for-Service Mental Health Billing Guide and is applicable to an individual, a client who is Alaskan Native or American Indian, you want to refer specifically to Part 2 of the FAQ. And if you're billing a service that would be considered in the Part 1 of the Fee-for-Service Billing Guide and is part of the physical benefit, and you're billing Provider 1 or an MCO, you want to look to Part 3 of the FAQ. I want to take a moment here to state that all of the managed care organizations and the BHOs and the ASOs are following these policies as well, as it's applicable to the service that they're responsible for. And some MCOs may have different tele rules in regards to how to bill, and you should follow their instructions, but pretty much they're following the lead of the healthcare authorities' FAQs. Just as a little tip, any service provided that meets the definition of telemedicine is billed using a place of service O2, regardless of what part, 1, 2, or 3 you are looking at. You want to use place of service O2. That represents telemedicine. The modifier that is required for that billing may be specific to the part of the FAQ that you are applying for preparing that claim. So you do want to follow the instructions specific to that part of the behavioral health FAQ. And then any service rendered using another telehealth technology, you would use the place of service that's specific to where the client is, not the provider, and you want to bill those services with a CR modifier if your electronic health record will support that. And that is applicable to all 3 of the benefits that are described under Part 1, Part 2, Part 3 of the FAQ. And just to note, the reason I say if your electronic health record will support that, we recognize that programming is difficult. We would like to maintain some kind of standardization in our data, but we appreciate the fact that electronic health records are not easily reprogrammed, and so we're not requiring that for payment. But just trying to be amenable to the fact that we want to support providers in providing services. We want to support payment, and we don't want to create obstacles to payment. This is just a list of, excuse me, policies that are available on our telehealth, on our COVID-19 website. If you haven't been there, you will find lots of valuable information on this website. There's a whole section that's devoted just to behavioral health providers. There's another section that's more general information that's applicable to anyone that visits the website. On this page, you're going to find all of our Q&As, all of the webinars that we've been doing already. You're going to find a revamped telemedicine telehealth brief that we finished up the end of last week. This is also where you're going to find the behavioral FAQ that I referred to earlier. And if you're an OTP provider, you're also going to find one that's specific to OTP services on this site. So we think that this is a really good site. We've been complimented by outside users on the extent at which we are providing information. And we're hoping it meets your needs, but if you need more than that, you can just email the agency and we will try to find something that supports you. So now I'll turn it over to the next presenter.
Thanks, Gail. This is Kathy Britton, and I'm going to spend some time talking with you today about Medicare and about private payers. And this is kind of like doing a great big dump right over the top of your heads. And I apologize for that. There's a lot of information. I may not cover it all directly, but I will be sure to answer your questions or find answers to your questions as soon as possible. Next slide, please. Okay, we've already defined who pays for telehealth. Gail just gave us a great overview about Medicaid in Washington. Again, I'll talk about Medicare, including the Advantage plans, private payers, ERISA, which are self-insured company plans, is the organization that oversees self-insured company plans, and patient self-pay. Next slide. Medicare beneficiaries are eligible for telehealth services if they're presented in an originating site located in a CMS-defined rural area. Original definition hadn't changed in years until the epidemic hit. The requirements were pretty stringent. The type of originating site had to be approved by CMS, the type of provider had to be approved by CMS, the type of service had to be approved by CMS, and the services must always be provided using two-way audio and video telecommunications that are HIPAA compliant. Okay, not much has changed in terms of eligible providers. This is the list: physicians, nurse practitioners, physician's assistants, clinical nurse specialists, clinical psychologists, clinical social workers, and FQHCs and RHCs during the COVID emergency only. Okay, Medicare did some expansion in 2019 that loosened some of this up a bit. They expanded and originating sites that will to include renal dialysis facilities, homes of beneficiaries with end-stage renal dialysis, mobile stroke units, and then the one that I think pertains most closely to you all is beneficiaries' homes when receiving substance abuse disorder and related mental health services. And the cool thing about this is that the geographic limitations that have been set down for payment under Medicare do not apply to these expanded services. Okay, under the COVID rules, Medicare will pay for services that are delivered to their beneficiaries in any healthcare facility and in their homes. These visits are considered the same as an in-person visit and are paid at the same rate as regular in-person visits. So with regard to the similarities between Medicaid and Medicare, this is exactly the same wording. And so basically Medicare says if you provide a service to one of our beneficiaries, they will be paid at the same rate as in-person visits. Okay, Medicare has also expanded the list of eligible services. And I've included the link to the list basically because this is a big list and they just finished adding 85 new services. But this is an easy to use list, and the link is right there on the slide. Medicare has also added FQHCs and RHCs to the list of eligible providers for the emergency period only, and that means that they can function as a distance site as well as an originating site. So services are being provided to folks from FQHCs and RHCs and can be billed to Medicare as of this time. Medicare will allow any mobile computing device that has audio and video capabilities to be used in the provision of services, but you can't use public-facing apps. So Medicare has not backed away from their original definition of telehealth, that it must be two-way audio and two-way video, but they are saying that you can use certain apps that maybe are not totally HIPAA compliant, that are not contained in a office setting, and that the big thing about that is that you can use your smartphone to deliver the audio and video. And the best part about this is that the Office of Civil Rights will waive penalties for HIPAA violations. And Medicare will not enforce the established relationship requirement. So you can see new patients as well as old patients, or established patients. I'm sorry, I'm an old patient. Established patients and still be reimbursed for those. The other changes they made is that a subsequent inpatient visit can be furnished via telehealth without the limitation that the telehealth visit is once every 3 days. So it used to be you could only do a telehealth visit using these codes once every 3 days. That goes away. Also, a subsequent skilled nursing facility visit can be furnished via telehealth without the limitation that the telehealth visit is once every 30 days. And this is the code. These are the codes that apply. Okay, Medicare has paid a facility fee to the originating site, and that's the huge amount of $26.65 per visit. And originating sites use the Q3014 code without any modifiers, and they submit the appropriate place of service. Okay, under COVID, the originating site is not limited to the list that was set forth by Medicare in their original rules, but because you're an originating site, be that in the home or in a non-qualifying site prior to COVID, you cannot apply for the facility fee. Medicare worked very hard to try to get additions made to the services that they would pay for years, getting past the two-way audio, two-way video. And finally, because they couldn't get Congress to move on this, they came up with a new classification of services that were called other technology-enabled services. And the way it was first explained to me, it's not innately face-to-face, but so that it is not telehealth, but it is technology-enabled services. And so when we talk about these services, we are not talking about the need for two-way audio, two-way video. First of all, virtual check-ins, which come under the HCPCS codes G2012, can be offered to established patients, or could be offered to established patients. There's no, providing there was no E&M in the prior 7 days or the subsequent 24 hours or soonest available following the check-in. They involved 5 to 10 minutes of discussion. But during COVID, the clinicians can provide those services to both new and established patients. And during COVID, the clinicians, including physicians, can now provide certain services by telephone to their patients using the codes that you see on the screen. Okay, e-visits are the remote evaluation of pre-recorded data using the HCPCS code G2010. And an established patient could send a recorded image or video through a patient portal. So they could send an image of a wound, they could send an image of a short video clip, a lot of things that could be recorded or images that could be sent through a patient portal were considered e-visits. The provider had to do interpretation and follow-up within the 24-hour period. And again, no E&M in the prior 7 days subsequent or 24 hours soonest available following. Okay, during COVID, the consults can be provided to a patient beyond the once per day limitation. So a patient can send multiple images in a day, and the provider can be reimbursed for it using these codes. And during COVID, a licensed clinical social worker, clinical psychologist, physical therapist, occupational therapist, and speech and language pathologist can provide e-visits. So where many of our therapy folks cannot provide telemedicine, i.e. two-way audio, two-way video services, they can provide these e-visit services under the HCPCS codes that you see on the screen. Okay, Medicare also allows for interprofessional consultations that are called e-consults. And there are 6 codes. There's 5 for the consultative physician and 1 for the treating or requesting physician, and those are listed. Those consultations can be provided by telephone, internet, the EHR, any number of ways. Their verbal and written reports are required, and there are certain limitations on frequency. Okay, under COVID, you can do those. Excuse me, I thought I had another slide in there. I shortened these for you. You can provide those without having to necessarily use excuse me, I lost the train of thought. If you have a question, come back and get me later. Let's move on to private payers. This is where it gets a little messy. Private payers are dependent on the laws and policies of the state that you're in. So whatever laws you have passed within the state that create telehealth requirements for private payers are the laws that apply. Many states have private payer laws. Some of them require payment parity, which means that they pay for telehealth at the same rate as they pay for in-person services. Others don't. And private payer reimbursement can extend beyond what's in the policy or legislation based on what the payer sees as a valuable service and what the payer and provider are able to negotiate into the contract. So basically, a provider who is providing a service that the payer sees as having a positive impact, even though he's not required to pay for it, can then have that written into the contract and the payer will pay for it. Private payer legislation can be found, basic information can be found on what I consider to be one of the very best policy websites in the nation. Is a policy that's run by the Center for Connected Health Policy. And they have a real easy to use graphic that allows you to click on the state that you're in or the state that you're interested in, and you can look at their Medicaid policies, you can look at their private payer policies, you can look at all kinds of information that pertain to that state. They are an excellent resource, and they have provided that information both on the state prior to the COVID response and the state's response and how that's changed the policies in that state. So excellent resource. I cannot recommend them highly enough. ERISA. ERISA is the organization that was established federally to have the ability to create self-insured company plans. Many employers, as you probably know, fund group health plans for their employees, and they're regulated by the ERISA Act, which is a federal act, and the plans have to be in compliance with state laws. They can't deviate from what that state mandates. Most just basically parallel the laws governing private payers in the state, although they could parallel the Medicaid laws if that's what they chose to do. And although ERISA doesn't have a policy on telemedicine, they recognize the value that telemedicine can provide to employers and employees, and they generally work with states to encourage the development of telehealth and not impose barriers to its use. As an aside, what we're seeing right now is some difficulties with ERISA payers and what they're willing to pay, primarily because they've had to lay off many of their employees or furlough employees, and what those plans, and they're a little concerned about the cost of what those plans will cover. So kind of keep your eye on what's happening with ERISA, particularly as it pertains to your state. Okay, patients can self-pay for telehealth services if that's their choice. And for some, that has become a way to get healthcare services if they don't have insurance or if their insurer denies payment. This especially occurs when the services are direct to patient, and we're seeing that in virtual urgent care. We're seeing that in behavioral health services. We're seeing that in substance abuse disorder services. So people, and as I said, people without insurance and seniors, particularly early on with Medicare, are often willing to self-pay in order to get the services they want. Before COVID, Medicare did not pay for many of the services that seniors wanted to get, so they were willing to pay for them. Payers are seeing positive data generated by these services and are offering their own products. And this is a blessing and a curse, because there are many more avenues to receiving direct-to-consumer services, but payers have been very quick to establish panels that contain their choice of providers for those services and exclude many of the local or state providers in the process. The other thing that we see with private payers has to do with removing the copay and basically the copay from and not charge those patients as Medicare has requested. And so there's been some discussion around how to make that happen. Private payers sometimes will tell you that, well, it takes a while for us to catch up with what's required. If you feel like that a private payer is not living up to what was agreed to under Medicare or under your state Medicare laws, please feel free to call your insurance division and talk to your commissioner. If they have laid out guidelines for payers, they may not be able to enforce them. However, when it comes time to renew that payer's contract to provide services in your state, and they've been very difficult to work with, they may find themselves facing some real hard questions in order to renew their contract. Okay, things to keep in mind. Telehealth reimbursement doesn't look like it did prior to the pandemic, and it'll not necessarily look the same after the pandemic ends. And many are hoping that the laws will remain as they are now, but if you are developing a solid business plan for telehealth, don't build it on what you hope will happen, but keep it on good quality return on investment and sustainability standards. And telehealth providers have the remarkable opportunity right now to show that telehealth can function better in this relaxed regulatory environment by keeping good data for our services during this time. And I have one provider say, I have enough trouble keeping up with providing the service. How the heck am I going to keep up with the data? It's the data that's going to mean the difference between whether Medicare extends these policies after the COVID pandemic is over or whether they pull them back. I agree the genie is out of the bottle in some instances, but I also know that the effort to make some of these pandemic laws permanent are going to be determined by the kind of data that are submitted by providers. Okay, this is just a fun one. This is a herder shed out on one of my family's pastures, and this guy is out there by himself, and there's not a lot of help that he can ask for. You guys are not by yourselves. You have incredible access to support and help, and I would urge that you would seek it out. Okay, I have the next couple of slides, and you can just kind of keep scrolling through them because they'll be available to you, are just resources that we put together that can help you and get your questions answered about reimbursement for telehealth. And if you just want to keep scrolling through those slides, there's some for each of the groups that I've talked about. NRTRC is one of the absolute best resources for all questions telemedicine. We recently finished a conference that ran over the span of 3 days, and all of the incredible information that was provided at that conference has been recorded, and all the slides are available at this site. Just click on the speakers dialog box, and you'll have access to all of that information. And if something that you're seeking is you don't find there, feel free to contact them. And one of the things that we kind of go by is we may not always know the answer, but we always know where to find the answer. And so we're happy to do that for you. And that's my contact information. And I think we'll turn it back to the moderators for Q&A.
Great. Thanks so much, Gail and Kathy. These are excellent presentations. I think you've done an amazing job of presenting because we don't have a whole bunch of questions, but I'll read out the couple that we do have, or oh, maybe some more are coming in now. So the first one is, what if one of your regular office hours already is on Saturday and we now use the 99050 and 99051 on Saturday's visit?
The one code that I provided there is the code that you would bill even if you have regular office hours doing outside of the parameters that I presented on the slide. So we're still going to pay you an additional amount of money for participating in a telehealth service outside of those hours. So anything on the weekends or anything after 5 o'clock or in between 5 and 8 in the morning.
Great, thank you, Gail. Okay, well, the next question, is there any sense for how long the CR modifier will be authorized for telephonic services and or what triggers or events will that decision be tied to? How much advance notice does the HCA expect to be able to provide before the transition away from using CR?
So I would offer to you that it's not just CR, it's the telehealth policies in general. And what we have talked about is we are very conscientious of the fact that it took us a while to rebuild the delivery model using telehealth, and it's going to take us a while to get back to where we were, if we can ever get back to where we were. So that's the big question. The Healthcare Authority will be working with the Department of Health and be consistent and compliant with any direction from the governor in regards to how he hopes to dial things back down. And we will not be looking to end our policies in any short time frame. We will work with providers. We will be considering what should be continued. As Catherine just described, if there's a silver lining here, we know from our data that the use of telemedicine and telehealth is being successful. And so there's an opportunity, just like Catherine was describing for Medicare and the private payers, that Medicaid will be looking at how do we maintain some of the things that we have accomplished? What can we still do within existing laws, primarily the HIPAA law, that we can sustain some of the momentum that we have picked up and delivering services. And I will offer to you, in working with the providers, many of you may have already commented, or your colleagues have said how much of a difference this has made for your providing services, and that no-shows seem to have been eliminated. And so we're going to work with providers as we figure out how we end up, if you would, or what our ultimate goal will be, is to have something things that can be maintained and sustained, and that we continue to provide services in some fashion. So as I said yesterday, no one should fret about us discontinuing this quickly, because it's not going to happen that way.
Awesome. Thank you. That's good news to hear. I'm delighted to hear that. Okay, and we have a question now for Kathy, I think. Do Medicare Advantage plans follow Medicare guidelines? For private payers that state they're following CMS, does that mean must be audio and video both to change to an in-person visit? Maybe change from an in-person visit.
Thanks, Cara. First of all, in the Medicare Advantage plans must follow the Medicare guidelines. They are able to expand, or prior to COVID, they were able to expand and offer those services to their clients. And in the past, they were not able to do that. They could, prior to COVID, during that expansion period, they were able to do so, and now they're able to do exactly the same as the Medicare guidelines. They can use the technology-enabled services as well as the telemedicine, two-way audio, two-way video. So yes, they are able to do the same kinds of things. Let's see. Do you want to read the second half of that question for me?
Sure. So for private payers that state they're following CMS, does that mean they must be audio and video both to change? It says to in-person visit. I think they mean from an in-person visit.
If they are going to bill it as a telehealth service, yes, they are following much the same protocols as CMS, so that they're making the differentiation between the telemedicine, two-way audio, two-way visit, and the technology-enabled services. And when you are billing a private payer, you would bill them the same way as you would bill the Medicare service, unless they state otherwise. And that's the other thing is, because we have a wide variety of payers involved in this, it's always important to check with the private payer and make sure how he wants the services billed and the modifiers that he wants used in order to not have to go back and rebill it when it gets rejected because it does not fit within the framework that he wants.
Okay.
Hey, Cara, I'm going to jump in just for a second before you finish up with the questions, and just alert everyone to the survey link that Rebecca has put into the chat. So if people will just take a few minutes to complete the survey. And just to double check about with the response to that last question about both the audio and the video, I think that was a question that I had as well, about whether audio alone could be billed at the same rate as a telemedicine visit across disciplines. So I don't know if that was intended in the question, but I had that question for Catherine and Gail.
Right now, if it can be billed the same, an audio visit can be billed the same as an in-person visit. The caution is that if the service can be provided using both audio and video, then providers are encouraged to do that. But recognizing that there are patients who do not have access to any kind of video service, the telephone visit is paid in the same way that a two-way audio video presentation would be paid.
So in regards to the Medicaid program, very similar to what Catherine's saying, we want to be clear that if you are providing a telemedicine, if you're providing an audio, video, interactive, real-time, HIPAA-compliant interaction that qualifies for the telemedicine visit, that you would bill it as a telemedicine service as instructed in the FAQs. However, again, recognizing that some individuals do not have the video option, and the only thing they have is a phone call, we are classifying that as a telehealth service. We're classifying Skype, we're classifying FaceTime, Facebook Messenger, the different type email. We are classifying that all as telehealth. And if indeed that visit does equate to a procedure code that you are, I'm going to use the word entitled to bill. I think that's the best way to put that. And that you would have billed a CPT or HCPCS code for that interaction if it had been in person. We want you to bill that code that best represents that service, and we will pay parity for that in-person visit. If that CPT or HCPCS code is not applicable, if the requirements for billing that code are not met, then we then offer those additional telephone call CPT codes, and they are paid based on time equivalent to an E&M of that time. So that was the easiest way for us to structure the reimbursement for those telephone call codes. Does that help?
There's a couple of questions that follow up on that, I think. One more of a statement, so they're not following CMS if they're paying audio only as in person. And then the other one is, how will a phone visit that exceeds 30 minutes be billed?
Is that for me?
Sure. Take a stab at it.
Okay. So wait a second. I need to go look at the FAQ, to be perfectly honest. And if the comment that we're not following CMS is directed at Medicaid, you're right. We're not. Our state declared a state of emergency before the national declaration. We had already started working on all of our policies and procedures and had things moving and in place, and we're creating everything to support the delivery of care in this new environment. And so we chose to continue to move in the direction that we were moving and not step back. And because we were so far down the line, the train had left the station. In regards to the behavioral health, so if you're billing a telephone call that is greater than, so yes, the maximum visit or the maximum code for the telephone call is indeed 30 minutes. So I guess I would offer to you, if you're interacting with someone for longer than 30 minutes, is there not a applicable CPT or HCPCS code that is also and maybe even more appropriate to represent the service that you are rendering? So your first option should always be in Medicaid to look for the CPT or HCPCS code that best describes the service.
I think we're going to have to stop there. I know there was one more question, and we'll try to get that answered and out in the FAQ. But just wanted to thank everyone for joining us. Reminder that the Behavioral Health Institute has a website that has a lot of great resources on it, including information and upcoming training and additional resources. Our MHTTC also has our website. Again, the survey, please do fill that out, because we're not only is it useful for us to evaluate our trainings, but also to inform the rest of this series and these sessions. And we want to get questions from you all and have our experts and panelists answer those. But our information is on the next slide. You can visit us online at www.mhttcnetwork.org/Northwest. Follow us on social media or email us at northwest@mhttcnetwork.org, where you can find out about upcoming trainings, new online trainings, and a lot of resources. So I think we'll end here. And once again, thank Gail and Catherine so much for a fabulous presentation and answering some really important questions. And remind everyone that this series will continue on Friday with Dr. Felker, and we'll continue with the Wednesday and Friday again next week. So thanks everyone for joining.